Hey, BC here. Welcome to BC Nephro. So when I was a student and when I was a resident, there was a lot of things about nephrology that just seemed like a mystery, just a big mystery. And I think that's what actually attracted me to nephrology. I wanted to be the one to be able to know and figure out these mysterious things. So some of the things that were mysterious as a student, as a resident, were dialysis. What is this all about? What's going on? Of course, acid base and electrolyte disorders seemed a little bit difficult, mysterious to how to figure out. But another one was the different types of glomerular diseases, glomerulonephritis. How to sort all these out? What's going on here? And that today, that's what I'm going to talk a little bit about. So we talked about proteinuria. There's some other videos about assessment of proteinuria, about the differential diagnosis of proteinuria kidney diseases. Now we're going to get into the nitty gritty. First one, minimal change disease. So I'm going to talk about minimal change disease a little bit. Try to keep it to like three things because I can remember three things. So hopefully most people can remember three things as well. So three things. What is it? How does it present? And how do you treat it? So pretty simple there. So minimal change disease is a pathologic just thing that is seen on kidney biopsy. So take a guess. On kidney biopsy, there are minimal changes. That's why it's called minimal change disease. At least the light microscopy part of it looks kind of normal, so that's why they call it minimal change disease. There's three parts of the kidney biopsy: light microscopy, immunofluorescence, and electron microscopy. The diagnosis of minimal change disease is seen on electron microscopy, where a part of the glomerular basement membrane called the foot processes are effaced diffusely all around the glomeruli. That means they're damaged. That means they're leaking protein. That means minimal change disease if the light microscopy has minimal changes. So most often this is idiopathic, can happen secondary to medications and Hodgkin's disease. Most common medication will be NSAIDs, but most often idiopathic. Next, how does it present? So this is the most common cause of nephrotic syndrome in children. So common that they often don't just give up. They often don't do a biopsy. They treat it like it's minimal change disease, and if it doesn't respond, then they're doing the biopsy. Can happen in young adults as well. So young people. The second thing is happens abruptly. So there's an abrupt onset of full-blown nephrotic syndrome, edema, 8-10 grams of proteinuria, hypoalbuminemia really low, like 2.2, things like this. Happens very quickly, onset like that. And there can be acute kidney injury associated with as well. This is not a nephritic RPGN acute kidney injury. This is an ATN. What happens is the hypooncotic state causes renal edema, ischemia, ATN. That's what's going on. Last thing, third thing, how to treat. So I'm going to go give a different video later about the different immunosuppressive drugs for kidney diseases, but this one mainly is steroids. Very steroid responsive. Use prednisone, 60 milligrams a day, and it usually responds at least in half of adults within a month. Then you can taper it after that. The problem with minimal change disease is not that they don't respond to steroids, although some do, but the main problem is that they frequently relapse, or they relapse when the steroids are tapered to a certain dose. In these cases, you need to think about a steroid-sparing agent. There's a number of different ones there. Calcineurin inhibitors, cyclophosphamide, Rituxan are the other ones. Going to talk about the different types of immunosuppressants, like I said in a different article. But for more details on the diagnosis and treatment of minimal change disease, check out the link at bcnephro.com. There will be a more detailed article. And as always, questions or comments, leave them below or email me, brian@bcnephro.com. And until next time, where we'll unlock some other mysteries of nephrology. All right, see you.